Hello, I'm Dr. Rafael Escamilla, professor in the Doctor of Physical Therapy program and director of the Biomechanics Laboratory here at California State University, Sacramento. In this segment, we're going to be talking about the structure, function, and pathology of the ulnar nerve. The ulnar nerve originates from the brachial plexus. Specifically, it's a terminal branch and direct continuation of the medial cord, receiving C8 and T1 nerve fibers and often C7 nerve fibers as well. So it's a C7 to T1 mixed peripheral nerve. Mixed meaning it contains both motor and sensory nerve fibers. So I want to first give an overview of the motor function of the ulnar nerve. So when you think of the ulnar nerve, it receives motor fibers that are going to innervate the 1.5 muscles in the anterior compartment of the forearm. The other 6.5 are median nerve. So the 1.5 muscles are the flexor carpi ulnaris, which is going to originate on the medial epicondyle for one head and the olecranon down here for the other head. And then it's going to come and insert on the pisiform in the base of the 5th metacarpal. So it crosses the wrist anteriorly and medially. So it flexes and ulnarly deviates the wrist. So that's one of the 4 superficial muscles in the anterior compartment. So with an injury, that could be some weakness in flexion and ulnar deviation. Then it innervates 1/2 muscle, and it is going to be the flexor digitorum profundus, the medial half. The lateral half is innervated by the median nerve. So what does it do? Well, first of all, it originates on the proximal ulna and the interosseous membrane. It's going to come down the forearm, under the transverse carpal ligament, through the carpal tunnel to the lesser 4 fingers. It's going to go deep to the superficialis tendons until it goes into the fingers, then it's going to go up through a slit and insert into the base of the distal phalanx. So one of the ways you can test for its integrity is stabilize the middle phalanx like this and flex the distal phalanx. So you're flexing dip, or the distal interphalangeal joint, like I'm showing right here. Okay, so that's it for the muscles in the anterior compartment. Just 1.5 muscles. The remaining 6.5 of the 8 muscles, known as the flexor pronator mass, because that's what they do functionally. They flex the wrist, fingers, and thumb and pronate. It only is going to innervate the medial 1.5. Most of the muscles that it innervates are in the hand. It innervates all the intrinsic muscles in the hand except for 2.5 muscles in the thenar region that control the thumb and the lateral 2 lumbricals. Those are median nerve. Everything else is innervated by the ulnar nerve. So let's go through those. First, there's 3 muscles in the hyperthenar region right here. They all originate on the medial flexor retinaculum and the medial carpus, your pisiform and your hamate. And the most ulnar one is going to be the abductor digiti minimi, insertion to the base of the proximal phalanx, and it's going to abduct the little finger like this. And then the next one is going to be the flexor digiti minimi. It's going to insert into the base of the proximal phalanx and flex the little finger at the metacarpal phalangeal joint. And then the last one is the opponens digiti minimi. It's going to insert over here on the 5th metacarpal and help with opposition of bringing the little finger over to the thumb. So those are the 3 muscles in the hyperthenar region, and if you have an injury to the nerve, those particular functions we just went over could be affected. Also, you have the medial 2 lumbricals. So the lateral 2 lumbricals are going to be innervated by the median nerve. So these are bipinnate muscles that originate on the tendons of the flexor digitorum profundus. They're worm-like muscles. They work their way up, and they're going to insert into the oblique fibers of the dorsal hood. So notice that when they come in, they're going to come on the palmar surface more. So they produce a torque that's going to flex the metacarpal phalangeal joint because they're below, as you can see here, when they're coming into the oblique fibers. And then they're coming into the extensor mechanism. So tension from the oblique fibers is transferred to the central band, which runs along the dorsum of the proximal phalanx, inserts into the base of the middle phalanx. Lateral bands come off of it down here, and it's going to form a terminal tendon that's going to insert into the base of the distal phalanx. And through this extensor mechanism, the tension that starts with the oblique fibers is going to help produce a torque that's going to extend the pip and dip, the proximal and the distal interphalangeal joints. So when you think of the lumbricals, think of the lumbrical grip. It's a common grip used in manual therapy, such as proprioceptive neuromuscular facilitation, where you flex the metacarpal phalangeal joint and you extend the pip and dip. But it's only going to do it for these medial two fingers for the ulnar nerve, the little finger and the ring finger. So if you have a problem with the ulnar nerve that affects the lumbricals, you have to make the lumbrical grip, then these two fingers do not want to work very well on the medial side. The lumbrical grip on the lateral side is functional from the median nerve. So those are the medial two lumbricals. Then the next are the interossei. You have 3 palmar interossei and 4 dorsal. Let's start with the palmar. The palmar interossei, the way you remember what they do is pad. P for the palmar interossei and AD to tell you they adduct the fingers. So when the fingers are abducted like this, they bring the fingers into adduction, adduction. There's 3 of them, so they're going to be unipinnate muscles where they originate on the same side that they insert, either radial or ulnar. So let's look at that. They're going to go, like the name says, interossei, they go between the metacarpals. So in this case, they're going to go, the first palmar interossei is this muscle right here as far as its origin. So it's going to originate on the ulnar side of the second metacarpal, and it's going to come up and insert into the base on the ulnar side of the proximal phalanx. So it's in position to bring the index finger in toward the middle finger. So again, its origin's here on the ulnar side of the second metacarpal, and its insertion is over here. Then the next one is going to be the second one, palmar interossei, is going to originate on the radial side of the fourth metacarpal, so in here, and insert on the radial side of the base of the proximal phalanx. So since it's coming over this way, it can pull the ring finger in toward the middle finger. And the last one, palmar interossei 3, is going to be over here on the radial side of the fifth metacarpal and insert into the radial side of the base of the proximal phalanx, so it can bring the little finger in. So in that way, the palmar interossei, they adduct and they also help the lumbricals produce the lumbrical grip through the extensor mechanism to flex the metacarpal phalangeal and extend pip and dip. If we turn our hand over like this now we have the 4 dorsal interossei. So the first one, these are bipinnate muscles, so which means they're going to originate on adjacent metacarpals. So dorsal interossei 1 is going to originate between the first and the second metacarpal bones, and it's going to come over and insert on the radial side of the base of the proximal phalanx. So DAB is how you remember the dorsal interossei. D for dorsal interossei, and DAB, AB, for abduct. So they abduct the fingers, they bring it out. So it has to be over here on the radial side in order to pull the finger out. Now this is an interesting one, the dorsal interossei. Because it attaches to the first metacarpal, it can also move the thumb. When the thumb's down here in abduction, it can move it up in adduction, ADD. So abduction, adduction, and it can also flex it over. So for example, using a key to get in a house, putting pressure of the thumb against the index finger, you can feel very prominently the first dorsal interossei. And with an injury, this muscle could weaken and it could also atrophy and produce a concavity that's very apparent with ulnar nerve pathology. The second dorsal interossei is going to originate between the second and third metacarpals, and it's going to come up and insert on the radial side over here of the base of the proximal phalanx of the middle finger, so to bring the middle finger over toward the radial side. And then the third dorsal interossei originates between the third and the fourth metacarpals in here, and it's going to come over and insert into the ulnar side of the base of the proximal phalanx, so it'll bring the middle finger over to the ulnar side like this. And the last one is going to be over here the origin is between the 4th and the 5th metacarpal, and it's going to come and insert onto the ulnar side of the base of the proximal phalanx, so it can bring the ring finger into abduction. And the dorsal interossei also help the lumbricals produce the lumbrical grip, where they flex the metacarpal phalangeal joints and they extend pip and dip. So those are the function of the lumbricals and the interossei. Hyperthenar muscles, the only muscle left for the ulnar nerve is the adductor pollicis. So that's a muscle that originates as 2 heads, one along the 3rd metacarpal, the other one on the capitate and the base of the 2nd and 3rd metacarpal. It's going to come over and insert into the base of the proximal phalanx. So it can be stretched when you abduct like this, so its function is to adduct, to bring the thumb down. So this is abduction, adduction is bringing it down. You can test it better like this, holding your hand in this position, and then you have the patient bring their thumb up in this manner, and then you hold it there and you try to push it back down, like in this direction here. And that's also assessing the integrity of the first dorsal interossei as well. So those are going to be the functions of all the intrinsics of the hand that the ulnar nerve innervates, with one exception. It innervates half of the flexor pollicis brevis muscle, the deep half. The superficial half is, superficial head is from the median nerve. So the deep head, the flexor pollicis brevis, this muscle right here that flexes at the metacarpal phalangeal joint, is also innervated by the ulnar nerve. So all these muscles in the ulnar nerve are C8, T1. Most of them are primarily T1, except for the muscles that control thumb motion. They're more C8. So that's a good summary, I believe, of the motor function of the ulnar nerve. Now, sensory is very simple. When you're thinking of sensory, you're simply thinking of the medial 1.5 fingers in hand, both on the palmar surface here and on the dorsal surface. So the little finger and half of the ring finger is sensory, and the medial hand over the hyperthenar region, and then on the other side, same story. The 1.5 fingers and the medial hand in here. So that's your sensation. If you have an injury to the ulnar nerve, you could have abnormal sensation. You have a higher density of sensory receptors in the pads. So these 2 medial fingers are more likely to experience pins and needles, numbness, tingling type sensations with an ulnar nerve lesion. So that is a summary of the motor and sensory function of the ulnar nerve.